Okay. So this morning I'll talk about the treatment of glenohumeral arthritis. Looking at the outline, I'm going to talk about the biomechanics a bit first, and a very quick talk about epidemiology and the etiology of glenohumeral osteoarthritis, as well as history and examination, diagnosis, and have a look through the treatment options that are available for the glenohumeral arthritis. Looking at different type of arthroplasties that are available for this problem, and also a quick look at the treatment options that we have for younger people that are not arthroplasty options. In terms of the biomechanics of glenohumeral joint, it's a ball and socket. One of the characteristics of it is that the humeral head and glenoid fossa surface the ratio is about 3:1. It's a shallow joint. It looks like a golf ball and golf tee. Because of this, there's minimal bony covering and limited contact area between the two of them, and that will allow the extensive transitional and rotational ability of the joint. Comparing the hip joint to the shoulder joint, we can see that it's much more shallow, less contact, and also less stable. So the shoulder joint is an unstable joint on its own. The effective glenoid arc is the area of contact between the two bones. This is the area during the movement that the two bones are in contact with each other, and it's pretty small. The whole biomechanics of the movement of the shoulder joint is based on something that's called the concavity compression, and all of the pathology of it, everything that happens that causes the glenohumeral osteoarthritis, is based on the changes in this concavity compression. What it means is the concentric rotation that happens within them is because of a compression of the humeral head to the glenoid fossa. It's a concentric movement that allows all of the movements of the shoulder in different directions. In order for it to happen, there are different strains that are available to make this movement to happen. There are static ones and dynamic ones. In terms of the static ones, the glenohumeral ligaments help the head of the humerus to stay in the center of the glenoid. The labrum is specific in the shoulder. It's got about 9 millimeters width that allows 50% depth to the whole joint, and that helps that the head of the humerus stays in the middle of the glenoid and allows the whole movement of it. The negative pressure is also another factor that's important, also the congruity. Muscles around the shoulder as well is another important restraint to the movement of the shoulder, and the rotator cuffs and biceps as well as the scapular muscles are important restraints to it. Any change in any of these restraints, for example, if there is a rupture in the labrum or if there is a cuff muscle tear, will affect that concavity compression and doesn't let the head of the humerus to stay and move in the middle of the glenoid. Due to any of the pathologies in the shoulder, what's going to happen, there will be some destructions in the articular cartilage. And the next thing that's going to happen is that the load distribution will be abnormal in the whole shoulder joint. After that, there will be some changes in the underlying bone, both in the humeral head as well as the glenoid. And the humeral head will become flat, and also there will be some erosions in the glenoid, and the range of motion will become a bit limited. The centering of the humeral head next will be lost, and due to these changes, and also the osteoarthritic changes in it, the head of the humerus will sublux posteriorly, and it stops the concentric rotation of the shoulder and causes the symptoms of the osteoarthritis of the glenohumeral joint. Looking at the epidemiology of it, well, as we know, osteoarthritis is the most frequent cause of disability in the States. Like any other cause of osteoarthritis, the incidence changes with age. The older we get, the more chance of getting it, and more common in the 6th decade. It's more common in women, and the important things about the epidemiology of it is that it all starts from osteochondral defects, and the incident and natural history of it is unknown. The reason for it is that a lot of patients may have these changes and may be asymptomatic, so they may not be picked up at the time. In studies that they've been done, some of them have even mentioned up to about 36% chance of having chondral defects when the arthroscopy is done for other causes. And that's an incidental finding in all of them. Patients tolerate them very well. They don't have much symptoms with those chondral defects that will lead to the osteoarthritis of the glenohumeral joint. Etiology, like any other causes of osteoarthritis, can be primary and secondary. Normally in the shoulder, it's uncommon compared to the other causes. The cause of the secondary OA can be traumatic. This also includes athletes, that the overhead athletes, because of the multiple microtraumas that they have and the chondral defects. They will have their secondary OA changes. Instability of the shoulder can also cause, because it affects that concavity compression and the centralization of the humeral head. Can be due to surgeries like stability surgeries that can be done on the shoulder, or any other operations can produce osteoarthritis long term. Like the hip, AVN is another cause for it. Same sort of reasons can be there, like alcohol, use of steroids, traumatic as well, can cause AVN, usually in the humeral head, as well as the inflammatory arthroplasty can be another cause. There are less common causes as well, like PVNS, that can cause glenohumeral osteoarthritis. In history and physical examination, symptoms may be non-specific, so patients may present with symptoms that they're not the commonest. But like any other cause of osteoarthritis, they will have pain, they will have loss of motion, they may present with mechanical symptoms. One of the important things about the history to ask is to ask patients if they've got history of trauma, if they had any operations done on the shoulder, if they have rheumatoid arthritis, if they've been using alcohol, if they've been on steroids, to find out what the main cause of arthritis is. The physical examination is similar to examining any other joints in orthopedics, to look, feel, move and measure. In terms of the movements, in a typical osteoarthritis, because of the posterior subluxation of the head, the movement that's going to be reduced the most is the external rotation. And one of the other things is you're going to be feeling crepitus in the examination. Examination of the neck is important because pathologies around the neck can cause pain in the shoulder, so it's important to identify it. And neurovascular examination is also important in examining the shoulder and upper limb. Usual diagnostic tests are used for it. AP, axial lateral, and scapular Y view are the commonest X-rays that we normally order. Striationometry can be helpful to look at the presence of Hill-Sachs lesion posterior superiorly, and it's important in early stages of OA. People may have a normal X-ray, but with that we can find out about the lesions, as well as the West Point view that can show anterior glenoid lesions. CT is good, can be a good tool for preoperative planning. It's going to give us some information about the glenoid bone stock. To choose what arthroplasty option to use, shows us the pattern of the blood loss, and also shows us about the version or if there's any changes in the characteristics of the glenoid. MRI is a good test to find out about chondral abnormalities, specifically in young people, that the X-rays may not show much change. Getting now to the treatment of the osteoarthritis, the treatment is based on multiple factors. The most important ones are the patient age and the level of activity that the patients will have. Severity of symptoms also will help to decide if joint preserving procedures are indicated or doing an arthroplasty is the best option for the patient. As well as those factors, radiographic findings is important as well, and also medical comorbidities will help to decide if a big operation is needed or a small operation like an arthroscopy is the treatment of choice for these patients. Like any other treatment, any other osteoarthritis or any other treatment in orthopedics, there are non-operative and operative treatment. The important part about the non-operative treatment is that it doesn't stop the progression of the disease. It helps with the symptoms. Again, it includes activity modification as a first step in non-operative treatment, physiotherapy or physical therapy, pharmacotherapy, injection of the steroids, and viscosupplementation injection. Looking at the different literature, as well as the latest that's been published in JOS, it is interesting that the evidence does not recommend any of them, doesn't even recommend the effect of activity modification. There isn't much evidence in it, as well as the physiotherapy. There is only one paper that shows that non-steroidals is better than using paracetamol and physical activity, but in general, even non-steroidals is not recommended as a treatment of choice. The only one between those non-operative treatment is the injection of viscosupplement. There is one study that's been published in American Journal of Sport Medicine that used Symvisc 3 injections within 1 week that showed some good result in pain and function of the glenohumeral joint. Other than that, there isn't more evidence in literature. Coming down to the operative treatment of it, we can do arthroplasty, or it can be joint preserving procedures, that there are non-arthroplasty options that can be used. Again, in younger people that they have chondral defects and not much change, the joint preserving procedures may be the best option, and older people, arthroplasty may be the best option to use in glenohumeral OA. Looking at the history of arthroplasty, the first joint arthroplasty was on 1893 by Jules Pien. He was a surgeon that was doing general surgical procedures, obstetric lining as well, and he designed the first prosthesis that was a platinum and rubber prosthesis. He inserted in a sailor that had tuberculosis, and that had to be removed 2 years later because of infection of the joint. And this is the prosthesis that he used, so they had it to be quick. There wasn't much happening in terms of progression development of procedures until 1951, that Navid developed his first prosthesis that he used in severe proximal humeral fractures. And after the revolution of it a bit later, in the 70s, the reverse shoulder replacements was designed, but they abandoned very quickly because of the high revision rate they had. And the first total shoulder replacement was called the NEAR 2, that was introduced in 1974. And that was a humeral component and all polyethylene glenoid component. That was the first one that was used. Hemiarthroplasty is an option that's been used, and we use it mostly in fractures. Different types of them have been introduced. The stemmed hemiarthroplasty is resurfacing ones, and also the CTA head ones, or the ones that they have an extended coverage head. Different indications for it. The most common one, as I said, is proximal humeral fractures. It can be used for primary OA. There is a bit of discussion, and we're going to look into it about using them versus a total shoulder replacement. It's a good option if there isn't much bone stock in the glenoid, and we can use this one. Cuff arthropathy, that was first described by Near in 1983, and again, the CTA head hemiarthroplasty is a good option to be used. And also in people that they've got AVN of the humeral head without having any glenoid involvement, hemiarthroplasty is a good surgical option. Resurfacing hemiarthroplasty has also been described in the literature. The advantages for it, so we can preserve the humeral head, all of the natural anatomical characteristics can be saved, the head shaft angle, the offsets can be maintained using this, and it's easy to change it later to a conventional total shoulder arthroplasty. It's a good option in people that they're young and they're active, and also athletes or patients that we're worried about the loosening of the glenoid component. There's a study that's been published in JBJS in 2008, and they looked at 36 patients below 55. They followed them up for about 38.1 months, and they've seen good improvement in their pain as well as their function. So the other option that's been used is the hemiarthroplasty with extended coverage head, or the CTA head. Normally what happens when there's a cuff tear, the humeral head will migrate proximally, and it starts articulating with both the humerus and the acromion. And the femoralization of the humeral head, that means that the tuberosities will become flat and congruent, as well as the deepening of the glenoid and acromion causes contact between the bones, and this continued bone-on-bone contact will cause pain for the patients. This happens as well if you use a normal prosthesis or humeral prosthesis. What it means is that this big head causes an articulation between the metal part and the acromion and the glenoid, and prevents rubbing of the bone on the other part of bone and doesn't cause any pain. It's a useful method to use in people that the humeral head is contained within that arc, but if the humeral head has been is unstable and there's anterosuperior instability, it will not be helpful and will fail. It's a good option to use in people with cuff arthropathy that they are young, comparing it to a reverse option because it allows further chance of revising to a total shoulder replacement. The most common used type of arthroplasty is the total shoulder arthroplasty. The ones that they normally use, they are minimally constrained anatomical TSA. They've got a stem humeral component and they're polyethylene glenoid. They're used in people with OA that they have an intact cuff. Inflammatory arthritis is another indication of it, and people with AVN, glenoid involvement. It's also used in post-traumatic degenerative joint disease. It's a bit about the use of it in inflammatory arthritis. The pathology is different, and also the radiological changes are different in inflammatory arthritis. People are normally in normal osteoarthritis, the head subluxed posteriorly, but in these sort of cases, the head is medialized. There is more erosive changes in the head and the glenoid, and the bone is more osteopenic. Due to these changes, problems and issues that we have is that we normally may need to use a cemented prosthesis in these cases because of the cortical thinning and the softening in the bone, and also the erosions of the head. And because of the decrease in the glenoid bone stock, the use of bone graft may be needed in people with inflammatory arthritis. Quick look at between the hemiarthroplasty and total shoulder replacement for glenohumeral OA. Generally, it's controversial. So both of them can be used. There are different papers. Some of them are for it, and some of them are against it. The AAOS recommendation is that total shoulder replacement is superior to the hemiarthroplasty for glenohumeral OA. One of the studies that's been quoted in both the JOS papers as well as a couple of other papers like the JBJS ones, they're saying that the assessment score on pain relief is statistically significant in both the total shoulder replacement, but the function and quality of life does not change that much between the two groups. One of the papers that's in favor of total shoulder arthroplasty is one that's been published in Journal of Shoulder Elbow Surgery. That was in 2003. That was a large multi-center study and showed that several parameters are significantly better with total shoulder arthroplasty. On the other side, there was a prospective randomized study with 2 years follow-up that's been published in JBJS American that shows no significant difference in quality of life measurements between the two options. Again, there are two recent papers that they've been published in JBJS in 2011 2012. But one of them shows that really the quality of life measures are the same in both of them. But there is another one that's the same period of time that's saying against and saying TSA is a much better option to be used. There is one meta-analysis that's been published in Journal of Shoulder and Elbow Surgery in 2007, and they looked at 23 papers. They had about 1,952 patients in it, with minimum follow-up of 43.4 months. And they showed that the pain relief, the improvement in range of motion, specifically forward elevation, and also the gain in external rotation is statistically significant with the total shoulder replacement. and they've got a lower revision rate when you do a total shoulder arthroplasty comparing it to a hemiarthroplasty. One of the other options that can be used is a resurfacing total shoulder arthroplasty. That the same as the hemiarthroplasty surfacing prosthesis that they use. It's good for bone preservation for further operations if they are needed. It's less complicated instrumentation, and you don't need to have a straight canal. So if there is a malunion, it's a good option to be used. The problem with it is because you're not resecting the humeral head, the access to the glenoid and the exposure will be a bit difficult to do this operation. And one of the other options is the total shoulder arthroplasty with the glenoid resurfacing. Normally people that they're young and they've got bad OA, and also manual labourers that they need heavy lifting and overhead work, they cause a major concern when they have osteoarthritis. The problem is that they want to be active and they need to use the arm, and that causes loosening and wear of the glenoid component. Beforehand, before the arthroplasty options, these patients were all treated with fusion of the shoulder. It was a good option because they didn't have any pain, but their range of motion was very, very limited. So to give them a bit more function, the option that was used was the use of a stemmed or resurfacing hemiarthroplasty for the humeral site, and also using the biological glenoid resurfacing. Different sort of grafts have been used and been recommended to be used. This can be fascia lata, it can be anterior capsule, as well as the tendon Achilles can be used. Two papers that they've been published about them, they showed good results. Both of those papers are done in the same center. One of them had 14 patients in it, and they used anterior capsule in 3 and fascia lata in 3 of them. The results, so that's 6 patients. And those 6 patients that they had, 5 of them had excellent result, and 1 of them had a satisfactory result. The other study, they had 34 shoulders, and they followed them up to 15 years, and they used different grafts. And from those people, they only had 5 that had unsatisfactory result. Interestingly, the graft that had been used in those groups that they were not happy was the anterior capsule tissue. And the other cause for them being unhappy with the operation was infection. It's a quick algorithm about what to decide and which option is the best surgical option for people that they've got arthritis and they've got an intact cuff. It's based on the age and what sort of changes are in the glenoid, and also if there is any abnormality in the humerus. So if they are age above 50 and there is an adequate bone stock, so it's easy, you can say that shoulder replacement is a good option. And if there isn't much glenoid bone stock, so a hemiarthroplasty is the best option to be used in those people. If they are younger than that and manual labourers, that becomes a bit more difficult, so the resurfacing hemiarthroplasty is an option. And for the glenoid side, the biological glenoid resurfacing will be the treatment of choice in them. Again, if there is AVN that's only involving the humeral head, the stemmed hemiarthroplasty is the way to go for the treatment. If there is post-traumatic changes and there is malunion, then resurfacing of the humerus and the resurfacing hemiarthroplasty is the option of choice for them. And the glenoid component can be done via TSA. You can do the biological glenoid resurfacing for them if they're young. A reversal shoulder arthroplasty is also an option. The early designs in the 70s were abandoned because of the design issues. Normally, those prostheses was lateralizing the center of rotation. That increases the lever arm on the glenoid prosthesis and was causing early failure and loosening of the prosthesis. One of the other things that I found interesting was that they said the original data was published in a rheumatology paper, not an orthopedic paper, that showed very high rate of failure. And one of the papers was mentioning that. The new prostheses that they've been designed, like Delta and SMR, they medialize the center of rotation because of this that decreases the forces on the glenoid side, and also that increases the implant survivorship, so the new prostheses are working better and we use them more often. It's, as we know, it's used in a way that in people that they've got a cuff tear or cuff arthropathy, and if patients had a shoulder replacement that failed and they've got cuff deficiency, that can be the option of choice. One of the things is to decide about people with cuff arthropathy to go either with a hemiarthroplasty or going with a total shoulder arthroplasty. I think one of the things that I've seen being done is the patient's age and their level of activity to decide which one to do. Younger people may benefit more from a hemiarthroplasty with a CTA head compared to older people, that the reverse shoulder arthroplasty is the best option. Also complications with this, high revision rate, chance of infection, and there are also radiological complications that with the new design, the chance of them happening is less. Again, if in a patient in irreparable cuff tear, if there is arthritis or there is no arthritis, treatment options are different based on the age. You can do a reverse total shoulder replacement or a hemiarthroplasty, and if they're younger, a hemiarthroplasty with a CTA head will be the better option. If they don't have any arthritis, they've got a cuff tear and they failed the treatment, then again, you can do either debridement or you can do a tendon transfer if they're young, or you can do a reverse total shoulder replacement. About the young people that they've got glenohumeral osteoarthritis, these people want to maintain a high level of activity, and this is because of recreational interests or even the occupational demands. A lot of these people at a young age, there isn't much change on in the normal X-ray, and they've got chondral defects that they can be found, and this is the first step in the development of the arthritis. So, arthroplasty is not a good option for them because of the implant durability, that it's going to fail earlier and they will need to revision much quicker. Their clinical experience has shown that non-arthroplasty options is a good option for them. They do pretty well, and that will delay the need for an arthroplasty in them. It hasn't showed that it stops the progress of the osteoarthritis, but the short-term results about it are pretty good. But there isn't much long-term results or evidence about how it works. Different classifications have been used. The other bridge that we use in the knees and the hips are the commonest that have been used in the chondral defects. There's also this classification that's the ICRS, or the International Cartilage Repair Society classification, that's pretty similar to the other bridge one. So in terms of what options are available in young people, it can be divided in reparative, they can be restorative or reconstructive. And the last option will be the palliative arthroscopy debridement. The other things can be done on osteotomies, both on the humerus and the glenoid, and arthroplasty also can be used in young people. The palliative arthroscopy debridement, it's used when the non-operative treatment fails. It reduces the pain and increases the range of motion and can delay the need for a shoulder replacement. It's a good option in people that they're above 65 and they've got low activity demand to avoid a big invasive operation. People that they've got a lot of comorbidities and not suitable for a shoulder replacement, they can benefit from these sort of operations. If there is capsular contractures that can be released through an arthroscopy. The other things that have been described is the humeral osteoplasty and also the transcapsular axillary nerve decompression. The inferior osteophyte that's around the humeral head can put pressure on the axillary nerve and can cause pain in the posterior part of the shoulder. And by doing the decompression, their symptoms can improve and they will have better range of motion. Based on what other pathologies are in the shoulder, subacromial decompression can be done, and distal clavicle excision as well as biceps tenotomies are the options. There's a paper that's been published in JBJS British that supports the use of the arthroscopic measures and doing the subacromial decompression, clavicle excision, and showed that improved the symptoms of the patients. Reparative options. These options have all been taken from the experience that was available in the knee. So it's the same sort of thing that's just been started to be used in the shoulder. The aim of it is to resurface a defect with fibrocartilage, with stimulating techniques of the marrow. It's good in defects that they are small, less than 2 centimeters, and the best results are very small lesions that are on the humeral side. But when we've got lesions both on the humerus and the glenoid, they will have the worst results compared to the other ones. If the reparative treatment fails, the next step is to do cartilage restorative options. And the difference is that this cannot usually be done through a single and simple arthroscopy, and they normally need an arthrotomy for them to be done. It's a good option in patients, again, that they're young and they're active, and they got isolated focal cartilage defects on either the humerus or the glenoid. 3 different types have been described. We have the autologous osteochondral transfers. You can do an osteochondral allograft, or as well as the autologous chondrocyte implantation. The last one is only used if there is only a cartilage defect, and if there are bony defects, it's not going to be useful. About the autologous osteochondral transfer, they're normally reserved for small lesions, about 1 to 1.5 square centimeters. Normally, that graft is taken from the lateral trochlea of the knee. The advantages that it has is that it can restore the glenohumeral architecture. It's a single-stage procedure, and it gives good osseous integration. Their unique disadvantage had got the donor side morbidity. There isn't much information, or there isn't much data in literature about it. It's just limited to case report and case series as far as I know. The other option is osteochondral allograft. What it does, the aim of it is to restore the congruency of the articular surface. It's good for large full thickness cartilage lesions on the humerus, and because it's an allograft, so there is no donor side morbidity. The disadvantage is the limited chondrocyte viability. The success of it is related on the number of the chondrocytes that there are in the graft. Again, the loss of the matrix structure is another problem, and transmission of disease is also the other disadvantage of this method. The different sort of grafts can be used. You can use the humeral head allograft, and also the tibia can be another allograft. It can be used proximal tibia for the glenoid humeral rims for these problems. Again, limited information is there, so case reports and case series about the use of this technique. The other one is the autologous chondrocyte implantation. It's investigational. Normally, you take the healthy cartilage, you culture and expand the cells for about 3 to 4 weeks, and then you go back and implant it. It's a potential way of fixing problems, basically superficial defects in the humeral head. Another option is the glenohumeral reconstructive options that, as mentioned before, can be used with hemiarthroplasty of the humeral head. Can be used in advanced disease that they can be on either the humerus or the glenoid or both of them. As mentioned before, different grafts can be used. You can use a local articular capsule. You can use autogenous fascia lata, Achilles tendon, and the lateral meniscus is one that can be used. Lateral meniscus because is much better than the medial one, and they say that if you want to use it, it's better to be a male lateral meniscus and better to be from someone that's less than 30 years old because of the thickening and the quality of the meniscus. The other tissues that can be used are the dermal patch or the processed tissue graft that can be used in this situation. Again, a quick algorithm about what we can do with young people. If there's a focal chondral lesion, you can do arthroscopy and microfracture first. If it fails, it depends on where the lesion is. If it's on the humerus, if it's on the glenoid, if it's on both of them, it's based on their age. If they're young, the restorative options like the autologous osteochondral autologous transfer can be done, as well as the allografts. If they are older, then the reconstructive and resurfacing options can be used for them. And in the glenoid lesions, the resurfacing options are the options that are available using the meniscus or the regenerative matrix. If you've got lesions on both sides, so you can treat the humeral side with the same thing that we said, and you use the resurfacing options for the glenoid. And if it fails and the patients are above 40 years old, then the total shoulder arthroplasty will be the next option. If you've got diffuse chondral involvement, then you can do the palliative arthroscopy, you can do a subocular decompression if there are impingement symptoms, you can do a capsular release if there's contractures around the area, if there's limited external rotation, and again, if they're above 40, the total shoulder arthroplasty is an option, and if they're less than that, the humeral resurfacing or hemiarthroplasty for the humerus can be done, and for the glenoid, the resurfacing is another option that can be used.